I mean, our mindsets are just two different places. One, we feel really, really sorry for this patient, and the other one, we're like, oh, it's that. What we want to establish there is that we have two compromised respiratory patients. If we look at the treatment of them, we take the patient, here's their PO2, here's their CO2. These are their bases. This is OSA base, and this is an OSA with ventilation. PO2 is 51, it increased to 64 with the obesity patient. With the hyposcoliosis patient, it was 55 and increased to 65. So very similar increases in PO2. We look at their CO2. Respiratory failure, 58 with the obesity and hyperventilation. We blew it off and got it down to 45. Same thing with the hypo. 59, blew it off and got it down to 45. What do you know? You take two compromised respiratory patients and you ventilate them, and they both respond like compromised respiratory patients because they are the same patient. Whether it's the hyposcoliosis guy or whether it's the obesity hyperventilation guy, they're compromised respiratory patients. We need to treat them like compromised respiratory patients. Recognize it and treat it. So how do we treat it? Volume targeted ventilation is one of the preferred methods. It's primarily a bi-level pressure support device, but it works to maintain a constant tidal volume. So where ASD was using the patient as its target, this uses a tidal volume that you set as its target. And it's going to change the inspiratory pressure in order to try and hit that target. It's pretty simple. Again, I keep using this clicker and it's not working. So, but the system is going to set itself or set a target here. You probably not even see that. I can't see it very well. There's a blue line right here. So here, this patient is breathing at their target, and they drop below their target. What ASV does, or AVAPS does, or volume targeted ventilation, starts to gradually increase the inspiratory pressure until it pushes them back up to their target. You'll see it better here in this video. So here's kind of what works on the fly. Patient's breathing along at their target. Their target is 500 milliliters. So BiPAP's doing its thing, inspiratory, expiratory. Now they move from non-REM sleep into REM sleep. So what happens? Accessory muscles disengage, aren't helping you breathe anymore, diaphragm's running the show, and their tidal volume drops to 390. So volume targeted ventilation gradually starts increasing that pressure support until it pushes them back to that 500 target. So it's going to be a more gradual change than it was with ASD. Now the patient gets out of REM sleep, accessory muscles re-engage and are helping out again. Ooh, now we're overbreathing. So it's going to start decreasing that inspiratory pressure until it drops them back down to the target of 500. And so it's going to continue to work like that all night long to maintain their tidal volume. This can happen with a sick lung patient as well. The same sort of scenario. They can be breathing along very fine, and then all of a sudden their lung compliance decreases, so their lungs are stiffer than they used to be. And so now what BiPAP was doing before ain't doing the same thing because their lungs are stiffer. So BiPAP is going to increase until it pushes them back to their target. So they start getting compliant on their nebs and all that stuff because they're feeling bad, and all of a sudden they're doing better and their lung compliance is better. Excuse me. And so now it's going to decrease. So on bad days, it's going to respond to help the sick lung patient. And on good days, it's going to decrease pressure so that it's much more comfortable for your sick lung patient. So it's going to work in either case there, sick lung case or obesity hyperventilation, any volume case. Remember, that's what I'm trying to get across there. So here's a random crossover study that was pretty interesting. It's a small N, only about 10 patients. But the interesting thing here was they tried them on all the different therapies. So I'll click onto that slide here real quick. So their baseline, here were their CO2s. And if you look at this baseline here, this is right around 54, 55 in the scale. And so respiratory failure had a wide range of it. but they were all on respiratory therapy. So then they put them on CPAP. And the range decreased, but look at the line. It actually went up a tick. So your mean went up on CPAP. Didn't help. So then they put them on regular BiPAP ST. And again, your range decreased, but what did your median do? It only went back to the baseline level. So still their CO2s are high. Then they put them all on volume targeted ventilation. Remember, this is the same exact 10 patients who wore each one of these therapies. And when they put them on volume targeted ventilation, look at that. Blows off CO2, puts them in a much improved range, and treated a respiratory patient on the respiratory patient instead of looking at him like that's that guy. They need to be ventilated. They need to be ventilated if they're hyperventilated. Titration protocols for these, again, it's very simple. Open the airway, let the machine work. Because you set a target for it. You set that 500, let it work. And so these mainly have more of a fixed. I don't know if you go to a ventilator, go to one of the advanced ventilation systems, then you have an auto cap in these, but for your standard BiPAP, volume targeted BiPAPs, it's a fixed EPAP. So most of them require sleep lab titration. You set that EPAP to open the airway, and then the device is going to work between the pressure ranges that we set. Do I need to go through that whole thing again? Good. I'm not doing a gator chomp. So it's going to work the same way. You set the target here, 500 milliliters. That's what I want you to breathe every breath. If you're using the ResMed system, then it looks at the alveolar ventilation. You're going to set that through a little that I'll show you here in a second. So different concepts, different ways of getting to the same concept. So you're going to have a range that you're going to allow. Do I need to close up that range? No, because I set it at 500. No. If it takes 5 centimeters of pressure support for it to get it to 500, it's going to use 5. If it takes 12, it's going to use 12. If it takes 18, it's going to use 18. And when it hits 500, guess what it's going to do? Stop. So max pressure, not that important. Minimum pressure, not that important. Let the machine work. All you need to do is set that EPAP to open the airway and let it work with an open airway versus trying to force a closed airway. So that's what you'll see in this titration protocol. If you look at the IVAPS titration protocol, you'll see it has a lot more steps there for setting your initial stuff because you have to put in that patient height and then you set in their patient rate, and it's going to use an ideal calculated body weight to set the volume target, and it's going to multiply that by the minute ventilation, and it's going to subtract the dead space to give you alveolar minute ventilation. So that's kind of how it works on their concept. Leave the pressures open, let it work. Set the EPAP to open the airway, let the machine work through an open airway. It is going to do so. So remember this in conclusion. Volume targeted ventilation is not recommended for patients with periodic breathing. Why? It's not fast enough. It doesn't respond fast enough, and for the intended patient group, we don't want it to respond fast enough. Because trying to pop out that particular volume every breath or responding to those changes every breath is just difficult for it to do. So treatment of a periodic breathing requires a variable breath-by-breath response so that they can stabilize their CO2 quickly. It prevents overshooting or undershooting in these patients who have a rapidly changing respiratory pattern due to their central events. But ASV does not, AVAPS does not have a quick variable response in tidal volume. It's designed to adjust and maintain a constant tidal volume with slower changes, like I showed about going into REM and out of REM, or good lung days and bad lung days, and adjust for those. So the benefit will often be seen in patients who have slow declines in their ventilatory conditions with volume targeted ventilation. So in summary, sleep disorders breathing is associated with cardiovascular disease. Cardiovascular disease is associated with more central respiratory events. And it's also associated with obesity hyperventilation, which are the underbreathers who need ventilation. Servoventilation is the modality for the fast changing flow patterns that are central in nature. And volume targeted ventilation is the treatment modality for hyperventilation, like obesity hyperventilation, a much slower changing type of disorder. But each modality then must be carefully managed in order to ensure a positive outcome. For the sleep techs, they're really, really simple. Open the airway, let the machine work. Get it. I have an old colleague who used to say, sit on your hands. I hate that. So, worse sometimes. Set the EPAP and sit on your hands. So that's how they work. Any questions today? I'm always scared when there's no. There we go.
How does the algorithm work if the EPAP's not appropriate? It's
still going to try, but you're going to see it probably pressure limiting itself because the airway is going to be closed and the pressure support's still trying to push, and it will probably start pressure limiting itself there.
Meaning it would hit the max.
It would hit the max, yes. So it's still going to try, but it's putting it in a tough spot.
Would the physician at home setting be able to see that and identify?
Should be able to see it, and actually I have, from experience there, it was really funny that I had a physician in Gainesville, Georgia, who was a really good sleep physician, who wanted to do some retitrations and asked me to come in and work with their techs on the night. And I said, well, can I look at the download first? And did, and I said, how about a couple of these changes? And he said, well, we'll make those changes, but I still want you to come and do it. And so we made the changes. I came in and we sat there and we didn't change anything. And then he had a volume targeted ventilation patient, and I said, can we look at the download and make some recommendations? And we did, and we went in for the titration, and we sat there. And then he called me back the next day, and he goes, okay, you got to show me how to do that. And so we went through download reading and read some of those things, and now he's like, okay, this is good. So you can see all that data. It's just, we spend so much time looking at, did they wear it 4 hours a night, 70% of nights, and and kind of stop there. There's a lot more data that you can get out of the download. And particularly for these patients, there's a lot of data that systems do. Others. Okay. Thank you all for having me today. I appreciate it.